All right, guys, welcome back. We're going to get into sexuality and sexual health. So what is healthy sex? So let's talk about healthy sex. Voluntary, wanted, pleasurable, and non-coercive, of course, benefits. So it always tells you that it's good for your cardiovascular health. You're working out, right? Extended lifespan, higher levels of happiness, life satisfaction. It helps with your immune functions, and it also helps you to have a healthier relationship.
And working out helps your sex.
Yes, exactly. It's a win-win.
Yeah.
Look at that. Let me pull the screen back down. So it should be viewed as an essential component of healthcare. So there you go. And as patients, you know that they have a right to have non-judgmental, open, direct communication, counseling, and therapy from their clinician or providers who regarding their sexual health and any concerns that they may or may not have there. So you can look at the boxes. I always encourage that. So let's talk about definitions. I know you guys can read that. So what is sexuality? What is sexual health? I'm not going to read those to you and bore you. Y'all can read that. And there's your sexual rights of all persons. And we kind of condense that. So you know, your rights as a person. Sex designated based on your chromosomes, your genitalia. So kind of what you were born with. Gender assigns roles based on your natal sex and sexual orientation. Trauma-informed care acknowledges trauma from various sources, assumes an individual is likely to have history of trauma, and of course we have to emphasize safety, both or all of the above, physical, psychological, and also emotional. So sexual practices and behavior. Sex positive position acknowledges that satisfying sexual activity stemming from sexual agency and sexual self-knowledge is healthy and desirable. It's kind of a mouthful. In many cases, cultural norms dictate what is acceptable, what's normal, what's acceptable. We kind of talked about this when we did our last lecture. Celibacy, what does that mean? It's the choice to abstain from any sort of sexual activity. A monogamous relationship, serial monogamy, that's one relationship
At a time.
Yep, at a time, then followed by another one.
Yeah, because sometimes in my clients, they have, if I see them annually, they may have a different partner.
Truly.
But they're serially during that year, only with that one person.
There you go. And it's important to ask these questions, and I think we've hit on that with the last lecture, but it's important to find out the social history of your patient and on what that looks like to them. Consensual non-monogamy, which is polyamory, one or more concurrent partners consented by all parties, and that's what we were identifying as swingers. You know, she had a patient that came in that actually said that she and her husband swing, so to speak, and so you have to understand even slang terms.
Yeah.
But then now this is the medical term.
Yeah, because that's what she used.
Yep, exactly. And I probably would have put that in quotes and put it in the note. Marital monogamy is assumed to be most desirable by many societies, and kind of already know that. There's sexual desire. And I find this kind of interesting, shaped by factors including familial and cultural rules. And y'all can read that. It's talking about the United States. It became important for the female desire in the 1960s and 70s. See, there's that preferences and expression change across the lifespan. Yep. Sexual self-knowledge. So a woman's ability both to understand her own arousal and its physical manifestations, and to recognize her own desire and even preferences. And there's arousal. It could be objective or subjective. Concordance or coherence, matching objective signs with subjective experience of arousal. Can't even see what that says down there, but I know I've got it on my slide. Anything there? That's okay. Sexual anatomy and physiology. Hopefully, you guys this should be kind of a review for you all.
Yeah, I'm sometimes amazed at the number of women who do not know their anatomy. And all the time they come in, it's like they found something they never noticed before, and they don't know the terminology. So, sometimes it's making them aware and educating them.
Yeah.
And, by keeping a chart of anatomy on, within my office, I pull it out all the time. So that I can, it's a teaching moment that I can tell them if they have a question about something or, parts of their bodies or whatever, but, yeah, they have a number of names for them
Yeah.
themselves.
No, I get it.
That-
I mean, when I get my 18-year-old and he comes up to me and he tells me these words that don't even make sense, like I'm telling you, you've got to understand slang, especially if you start seeing younger patient population groups.
But the older ones as well have their own slang.
Probably true.
Language
right.
for it. So.
You're right. You're right. So sexual response in women, this is, it involves capacity capable of experiencing an activity, that actual experience. So I'm going to go through some of this because I find all this kind of interesting, honestly. 2 principal physiological responses to sexual stimulation. So that's kind of like vasocongestion and muscle tension. Traditional female sexual response cycle, like that desire, the excitement, orgasm, and resolution. So there's actually a model, a Basman's model, based on the theory that women are not motivated towards sexual activity by predominantly physical urges.
Yeah.
So
And that's important to understand.
Yes, for sure. I find some of this interesting, and that's why I don't want to really kind of jump
It's
over it.
important to understand when they think something's wrong with them because they don't automatically have that urge.
Right.
And I have to explain that to them whenever they say, well, I've lost my libido. Well, what's going on with you? And well, we just had this baby and I've got a 5-year-old and I'm working full time. And by the time, and I've got diapers to do and I've
dishes to wash and laundry to, yeah.
And by the time that I lay down, I was like, I cannot wait to go to sleep. And he wants to have sex. And then he wants to know what's wrong with me. I was like, perfectly normal. Let's talk about this. So, I have to point out to her that all these expectations that she has for herself and everybody else has on her. And it doesn't automatically come up like it automatically comes to him.
Right.
And she thinks something's wrong with her. So I have to make sure that she knows that there's nothing wrong with her.
Well, that's good. Exactly.
Yeah.
Exactly.
To help her understand.
And I think that's so important because sometimes life gets kind of overwhelming.
Yes,
so
absolutely.
asking what's going on in their life can kind of help pencil in what may be going on. So sexual agency, which is a concept that individuals have control over their own sexuality. So I find that kind of interesting. Societal messages about female sexuality have been negative in the past. Give women the right to make choices about their sexuality, including initiating those sexual encounters. So support, as providers, support women's sexual agency through that counseling, just like Terry just said, and other tools, talk to them, have that dialogue, find out what's going on, and let them know that that's not a bad thing. It may be okay. So having control over your pelvic muscles, what's your, I know we've kind of hit on this already together with like urinary incontinence, so to speak, when we talk about pelvic muscles.
Right.
So seeing it from this perspective, strength of pelvic muscles has benefits. There it is, decrease urinary incontinence.
Right, exactly. Well, it's, I've had cases where women have painful sex. And so trying to talk with them to kind of figure out what it is that's causing their pain. And, oftentimes it's like, is it painful? Is your vagina painful, or is it deep, or what's painful? Just when he touches me. So, some women have, whether it's from trauma or it's just the way they are, they have really tight pelvic muscles. And so they can't have sex because the tightness of that pelvic muscle. So that's what that's talking about. This particular person doesn't have control over her pelvic muscles because they automatically tighten up. So that's when I encourage her to consider pelvic floor therapy, and it's actually helped to, in that sort of sense, with her and being able to have sex more comfortably. She wants to,
Right.
but she can't.
Yeah, physically.
Yeah. So, we lose control over our pelvic muscles over time after we've had pregnancies, and as we go through menopause, and our pelvic muscles get weaker and we lose our strength. So that's important to understand about those pelvic muscles surrounding those organs that we deal with.
Exactly. And we've talked about biofeedback also. So this is kind of the same situation, Kegel exercises, trying to strengthen those muscles down there. So what kind of products are there available to enhance sexual health? Sexual accessories,
Well, certainly they use them.
Do you ever promote that in your patient population group?
I don't know that I suggest that to them unless they specifically ask that, because a lot of women are offended by that.
Right. Yeah.
But when I have a patient that she may not be in a relationship and she talks about either her toy or a vibrator or a dildo, I have to let her know that that's okay.
Yeah.
I'll say that's the best way of having safe sex. So they do, a lot of them explore that, a lot of them don't.
Right.
And I'm careful to not suggest something that's gonna, like the type of lubricant that they use, that's not gonna cause irritation.
Right.
Or could promote an infection. So it's
but you have to be knowledgeable.
Absolutely. You can
stuff.
pull that up online, and you can find a number. I did that one day because a patient had asked me a specific brand. So I pulled it up, and it was like, whoo, a whole list of things I had never heard of, but then some I had.
Right.
And so, being aware of particularly the non-irritating lubricants is important.
And didn't you have one patient that used a lubricant that she bought at Priscilla's or something?
Somewhere that for anal intercourse, and but she was using it because she had painful intercourse, not anal course, but intercourse.
Yes.
Which was okay to use as well. And I can't remember what specifically was causing the pain, but that's what she used. It basically had some lidocaine in it. So, yeah.
So you have to be ready for those conversations. I'm sure your work really appreciated you Googling that stuff whenever they wanted to see what your history was.
They know where I was going to.
So it's okay. It is okay as providers to make sure you're knowledgeable of these things, because that could be a conversation that you may have with somebody. Just look at that statistic right there. Over half of your women are going to be using vibrators. So, and they come in all shapes and sizes too. So we have to think about trauma. Even
exactly.
To my opinion, or in my opinion.
Well, and if you have somebody that says, is it okay to have anal sex? Well, if you don't want to have anal sex, no, it's not okay.
Right.
And you have to tell them about the consequences of infection, not being, losing the sphincter muscle control. Yep, that happens, and can't go back and fix that. So they need to be aware of that. So being, I guess experience helps, but being comfortable talking about sex is something that we need to be as providers, so that your patient can come to you and 100%. Ask you, and they may be embarrassed first, like, okay, it's okay. I've heard a lot. So you're not going to surprise me whenever you talk to me and ask me these questions.
So true. So true. So sexual health, the assessment history is the first step always, right? Sexual health care. make sure you provide privacy, guard against any negative reactions. I know with mask, we were talking about that as well. With your mask, you can kind of hide, but I don't know about y'all, but you can see my eyes and my facial expressions. So, are you careful about how the patient perceives you and how you react to something when you're having these conversations? You've got to really kind of understand yourself. Look at yourself in the mirror and see with your mask on and try to look at that. I think that that's so important as providers. There's start with the easiest material, avoid medical terminology. I am telling you, they don't know it. When you say certain words, it's like a foreign language to them.
Well, what I don't want to not teach them what the labia is. So I'll say the labia or your lips of the vagina, because that's what they know.
That's what they know.
Yeah.
Yep.
Yeah.
So
they need to hear me say the correct terminology.
Yes.
But to help them understand that I'll say the slang if I know it.
Yeah, exactly. If I even know it. Exactly. So you see that focus on behaviors, practices, woman's perception, always important of her sexual experience, rather than those labels about sexual orientation. So there's a physical exam may be indicated by the history if need be, just like we said about the pelvic floor. That would be one where I would be like, yeah, well, let me, let's take a look. Let's kind of inspect this a little bit further to see if that's, there's something going on down there that we can really
and that's where your bimanual comes into play and help them, as this can be in any part of your pelvic exam. I can touch their bladder, put some pressure on that. Up there's your bladder, and does that cause you pain? Right here is your cervix and your uterus. Does that cause you pain? This is the wall of your vagina. And it's not really up against anything but other than muscles and tendons. It's that painful.
Right.
So
it's so important to help guide your physical examination. So there's also special considerations that we as providers need to look for, that proactive questioning support regarding their sexual life at particular times, even medications, medical conditions. Those are always there. We have to understand that. What medications used to treat. I know Terry was talking about there's some medications out there to increase women's libido. So there are those out there as well.
But being aware that certain medical conditions all the time, diabetes, depression medications, depression in itself, any of those can affect the sexuality and libido. So but I've got a list of medicines that, I may be familiar with or maybe not. I keep at my desk because if they express that they are experiencing, low libido or just not interested in their husband or whatever, I'll go through their medicine and see if there's anything that might be suppressing their libido.
That's so smart.
They need to know that because they think it's them.
No. Well, a lot of, as well as I do, there's some antidepressants, that we all know, some antidepressants that was like, you'll never have an orgasm and you're never, and you would not believe the women that are like, nope, no more, I've got to switch.
Yeah.
But that's a communication thing that you have to talk, like you said, if that's what it is, are you willing to switch over? Is that medication,
right.
And that's one of those things that they're going to have to figure out what's more important.
Exactly.
And if they're ready to switch over, because that can be a process too.
And sometimes you'll find they don't want to change medicines. It's okay, I'll handle him, but I don't want to change my medicine.
Right. That's what I'm saying. Yeah, of course. So adolescents, those between the ages of 12 and 19, when they start experiencing puberty, learn about their own body functions and relationships and that kind of thing, and develop that personal sexual value system at that age. Then there's the pregnancy and postpartum, of course, changes in that sexual function throughout each trimester. And then when that child is born, that may also impact, sexual function.
Oh,
And there's the midlife.
it does impact us.
Yes, it does. 100%.
Yeah.
There's your midlife,
Mhm.
when the children leaves home, when the estrogen levels start to kind of fluctuate and start decreasing.
But many times in the 40s, I will
That's it.
find that that's when their sexual activity enhances. Once that empty nest begins, they have fun
Oh.
and they don't have the worries. Most of the time, by that time they've taken care of their contraceptive needs or whatever, but they don't have the children may be off at college or children are out of the house, and that's almost a relieving freedom for them whenever it comes to their
That's
sexual
awesome.
life.
That's awesome. Older women, these are your 65 years of age and older. A cultural view of older women has a negative effect on sexual life.
Mhm.
And then, of course, the influence of culture, the upbringing, religion.
And that's huge around here.
Yeah. And the myths for
In the
each.
midst of Bible Belt, it's huge.
It is. It is. And of course, we can't forget those websites, any kind of media for sexual education websites that sell sex toys and that kind of thing. Some resources in your appendix 12A in your book.
Yeah, you have to be careful when you pull up that, but there really is some medical devices that you can pull up as well that can be prescribed.
That's awesome. All right, so we're going to lead into, last but not least, chapter 18. And this is alterations in sexual function. So definitions of sexual dysfunction. It varies among women. Definitions are inconsistent. So there's a lot of things that you guys can read. There's problems with desire, arousal, or even orgasms. Then there we talked about that, the sexual pain disorder,
Well, we talked about the vaginal, but there's also vulvar pain and called vulvodynia or vestibulitis. Either one is that's a little, it's very challenging to deal with. But then there's not any definitive treatment and you just kind of have to help them through that. So when you were asking me or talking about the lidocaine, sometimes in some instances we use the lidocaine gel in those areas so that and that's more on the external of the vulva. We use that. It doesn't numb him, but it lets her be more comfortable so she can actually have penetration.
Wow.
Yeah.
Good to know. And then you have to say, then there's that point where you have to say, well, is this a problem? Like, are you saying that it's a problem? Is he saying it's a problem? What does that communication look like? So let's see, associated with distress and determinants of treatment seeking study. So there's a study and there's some statistics with that. 44% of the women in that study reported sexual dysfunction, 39% is a low desire, 26% was low arousal, and 21% with orgasmic difficulties. So
I think that is interesting because when women say that, particularly young women, they're exploring, they maybe new to the relationship, or they may be newly married, and they are wondering about orgasm, and it's like, well, let me just tell you something out of experience. That's what I'll tell them.
yeah,
That it does take you a little bit longer to become aroused than it does him. So you just have to teach him of what feels good for you and give you time. So they need to realize that because they're not educated on that as well.
Yeah, I think having those conversations are really important. And I saw my preceptor have conversations like that with her patients. And, I think that's so valuable, Let's see, developmental health related partner relationship factors. So we have to take into consideration what's going on. We have to get that out of them, right? General assessment for sexual concern. So it says assess their health history. And we kind of talked about that, get a thorough health history. See surgeries, injuries, chronic illnesses, medications, allergies, like you said, partners, relationships,
Mhm.
have you had those critical conversations with your partner to help with some of the issues you may or may not have? Do you have major depression? Are you on medications? Some of those questions. Do you have mental health issues? Are you on medications for that? Because remember, they may come to you, but they've gotten these medications
From
from
another
their
provider.
primary care provider.
Or even a psychiatrist. Yeah.
Exactly.
So, it's just like, well, this is what, and I don't get into changing a psychiatrist medication. But when they are expressing to me, it's like, this is a conversation that you need to have with your doctor. So he's knowing what you're talking about, or she's knowing what's going on with
That's
you.
why I like multidisciplinary care,
Mhm.
because you can have all those pieces in place and we can all work collaboratively. There is a female sexual function index. Look at that. Which takes all those things into consideration. And have we made sure that there's no lab tests? So what is there certain things that you may draw on
You can
patients?
look at their testosterone, free and total testosterone. You can look at the estradiol. It may or may not tell you a whole lot, because most women have the normal hormone now. After menopause, that does change. And that's when we see low sexual desire. It's expected after menopause. So in some women, I can do those tests.
Is there anything else that may be abnormal in these patients in particular? Thyroid's okay?
Well, and making sure that thyroid, that they're not anemic.
Right. Cause them fatigue even. I mean, I don't know. Some other things could play in.
I mean,
guess.
it's a multitude
know.
of things, because, if there's a lot of stress going on in their life, they're going to wonder why they don't have a libido. Well, it could be job, it could be family, it could be, not necessarily her relationship with her partner, but it could be family stress. So, delving into that is, do you have a little stress going on? What's going on with your job, with your home life? Or, a lot of teenagers don't have a place to go and have sex, so they think something's wrong with them.
True.
Because they don't feel comfortable having sex in their house,
Yeah.
because their parents might find out. So you got to figure out all of that.
100%. 100%. So here's some differentials. It says there could be overlap of two, just like we kind of already narrated that a little bit. So there could be several factors to take into consideration. Is it psychosocial or psychological, physical, or a combination of both?
And I mean, it's the same scenario as a new mom. Now that she's got this baby into her and her spouse, partner, or whoever's relationship, that's new to them, and her perspective changes. And so it's understanding what's going on with them.
100%. So sexual interest / desire disorder. And how long has this been going on? Is this new? Is it been going on for a while?
Does it stem from a childhood trauma, or even a relationship they may have had as a teenager, or there's just
so many factors. There's negative factors that could potentially affect desire. Could be difference in the expectations between the woman and her partner, so to speak. Change in desire, could be change in sexual frequency, and investigate the timing of relationships. What occurs after intercourse,
If he gets up and goes home to his wife,
hello.
Yeah, exactly.
Then we've got another batch going on there. We've got other problems completely. There's menopause. You just said that. It's really kind of funny. Hormone deficiency could also cause, which you just said, that would be maybe a diagnostic or a laboratory test that we would potentially get. Aging process can cause that abnormal desire, life changes, so to speak.
Mm-hmm.
may help, individual or couples counseling,
Yeah,
sex
absolutely.
therapist, right?
And I used to know a nurse practitioner who had a um, counseling background, and so that was her practice. She was located eastern part of the state, and oh, how I wish that I had her, closer here.
Yes.
Well, now I think she's probably close to retirement, but she's on the coast now, so I have no
That's cool.
yeah, but I wish we had more that was in that kind of realm that we had available to us,
Yes.
specific counseling.
Yeah.
And I think I may have shared this before. I have referred to a counselor, even if he's not interested in the counseling, she might be
Right.
interested, or whatever the
Vice
case may
versa.
be.
Yeah. Yeah, of course. So there are some sexual arousal disorders due to potential physiological conditions, subjective sexual arousal disorder.
Well, an example of the absent or impaired genital sexual arousal, I
Mhm.
have a patient who struggles with that. She's a young woman, and she's had a multitude of surgeries. One is she did have endometriosis, so she's had, a hysterectomy, and her ovaries were removed. We're replacing her hormones, but also she's had a lot of pelvic surgeries due to adhesions. She's had mesh because of hernias. And amongst all of the surgeries that she's had, she's got some nerve damage. And that's what I've worked with her for a long time, and I think that's where we are. She's had so much nerve damage that she is not able to have an orgasm.
Oh, wow. Wow. So management of sexual arousal disorder, ask whether experience vaginal lubrication or feelings of genital engorgement. Determine whether the woman's having adequate stimulation to get them aroused. Are they getting where they need to be? I know that's something my preceptor always talked about. Do you have foreplay? What does that look like? Does it get you where you need to be?
It's okay to have clitoral stimulation, because a lot of women cannot have a vaginal orgasm.
Right.
So, they need to know that that's a normal
Yes,
thing.
Absolutely. Smoking and alcohol use can affect a woman's ability to achieve, but and we all know what smoking can have on the body for sure. How do we manage it? The vaginal lubricants, of course, help increase stimulation. Estrogen therapy localized.
Well, that's for the postmenopausal woman,
Right.
And that's needed in order for not only to prevent pain, but also that engorgement, that genital engorgement. She needs that estrogen there for that tissue to be engorged.
Right.
With arousal.
Sure. And then, of course, we have the complementary alternative treatments that could be available. But what if we have a female orgasmic disorder, like a delayed or a decreased frequency or absence, even an absence of orgasmic sensation lasting more than 6 months?
Yeah.
And what we have to rule out, is this a medication induced problem? What are we dealing with?
It's multifactorial, trying to figure it out, what to do with this.
Right, I agree. So inability to achieve orgasm related to lack of sufficient stimulation. So we've kind of talked about that, I guess, that arousal factor. The orgasmic reflex may occur, inhibition of that orgasmic reflex may occur, and it could be a psychological reason. They can't really wrap their brain or get into that scenario, or what if they're having pain down there? They can't get into the mood or that kind of thing. Yeah. There may be an underlying cause.
Well, the underlying cause is a big thing that I see because of chronic pelvic pain.
Yes.
And they it's usually say, I'm not able to have intercourse. I've tried everything. And, I might have been the one that's working with them and they're still not comfortable to have intercourse, but, they explore other ways of showing intimacy, even if they can't have intercourse. And that usually comes with the loving partner of what they are comfortable with and comfortable exploring as well. It's really heartbreaking when you do have that patient who has such pain that she cannot tolerate intercourse. So, I've seen that a number of times because of interstitial cystitis or sometimes fibromyalgia. So there's a lot of reasons why that somebody may have chronic pelvic pain and can't tolerate the intercourse. So helping them to, and I usually don't have the other partner there, but helping her to understand that they can explore other things and that's okay. And oftentimes women will express to me that that's what they've done within their relationship with their partner.
And that's going to be a difficult conversation too for them and their partner. Dyspareunia. I can never say that word.
Well, it's a dyspareunia, and this is what I'm talking about. This chronic pelvic pain with intercourse. They may be having pelvic pain, but it may not hurt with intercourse. But oftentimes, chronic pelvic pain and intercourse go in hand. Dyspareunia go hand in hand with each other, and it is a hard beast to manage. And sometimes this is what I was talking about with the tight pelvic muscles and pelvic floor therapy. That's a one of the ways I can help somebody. They got to be open to it though. They got to be willing to be able to try that. To work with usually a physical therapist. This is where that treatment depends on etiology of pain. So if it's interstitial cystitis that's causing that pain, if it's psychological trauma that's causing that pain, that will be a different way of approach. 100%. Vulvodynia is something we see fairly often. There's not one treatment that works for everybody, and I fortunately got to work with a incredible physician that was so interested in chronic pelvic pain and helping these women, and she veered into the treatment of vulvodynia and dyspareunia. And, even something like amitriptyline. Amitriptyline taken continuously can sometimes help with the nerve endings of pelvic pain. But finding the source of this pain and, trying something like amitriptyline or Cymbalta, which is both for depression, but has been found to help with chronic pain receptors.
It does.
And then the same thing with vulvodynia. You look that up, and there's not a lot of help for us as providers to help somebody with vulvodynia, but amitriptyline is one of those things that we can delve into. That's the use of lidocaine. And even compounded medications that with gabapentin.
Seriously.
So there's some resources out there that you can find that you can delve into as a provider.
That's awesome. So antibiotics for infections, corticosteroids for any kind of dermatological disorder. And then there's those non-pharmacological, and you just said all those really and truly, the pelvic floor muscle therapy.
Cognitive behavior therapy, we use that a lot as well. And then acupuncture. You'd be amazed at the number of people that is willing to consider acupuncture.
That are open.
Yeah. And if they know I'm open about it, some medical doctors, they'll go, okay. But I have found that is a very helpful modality to treat.
Hey, if you're,
Yeah.
if you've got an issue,
I don't.
I would be open.
Well,
to
I don't
any-
push that on them,
Right.
but I will say, have you ever considered
Right.
acupuncture?
Let's talk about your options
Yeah,
here.
yeah, that might be worth exploring.
Right.
You know,
Have you had
so-
really good outcomes with that?
Yeah, well, sometimes, and then sometimes not. So they have to realize that it's not a treatment, but it's a therapy,
Right.
that it's ongoing. And if they get some relief, from however that works.
Right. That's
my
right.
mind is
Yep,
backwards
I
to
don't
that,
either.
but however that
Right.
works, and they do find some relief, it's not a one-time shot. They've got to keep going to continue with working with their acupuncturist. So
That's awesome. All right, then there's that referral to a therapist, and we kind of picked this, we kind of talked about this a little bit. That sex therapist.
yeah,
or
and that is so
counselor.
specialized. Finding that person who is specializes in sexual dysfunction is really difficult to find. But I called a counselor, I don't know, several months ago, to work with one of my patients who, I don't know if I could not pinpoint if it was her upbringing but she was newly married, about a year and a half, and hadn't even attempted having intercourse with her husband. He even came in with her. It just broke my heart that, she had waited till marriage. He had waited with her. They got married, and he's nothing. And she's wanting to try, but can't make herself do it. So I called a counselor, a therapist that I knew, and she was able to work with her.
Wow.
So I haven't gotten any feedback just yet, but I'm hoping that
To be continued.
yes,
Would love to
yes.
know what the outcome of that is, All right, guys, that ends our session. I hope you guys learned something today, and we'll continue with the next lecture in a bit. Thanks for joining in.